Lots of students ask me for help with the addiction unit. While I don't have longer videos, I have made this revision video. I've also included a set of flashcards for this unit in the SiteBoost app. My app is designed to test your knowledge of all the topics in the A-level actively. It's on iOS and Android, and if you want to try it out, all of Paper 1 flashcards are free. If instead you want tutorial support videos of questions from all 3 papers, you can access over 16 hours of these, as well as hundreds of printable resources over on my Patreon. But enough of that, let's get started. Describing addiction. Addiction, a mental health disorder defined by compulsive drug seeking or behaviours. Addictions can include physical and/or psychological dependence. Physical dependence. Over time, the body physically adapts to the presence of a substance. This results in tolerance to the current level of the substance, and if the individual stops taking the substance, the body experiences an unpleasant set of symptoms called withdrawal syndrome. Psychological dependence. The mental compulsion to take a substance, carry out an addictive behaviour. The individual believes that they need to keep taking the substance. Its absence results in psychological effects such as anxiety, irritability, depression, and cravings. Psychological dependence can be experienced without physical dependence. Tolerance. A state of adaptation in which exposure to a drug causes physical changes that result in a reduction of the drug's effects over time. This means that the individual needs an increasing amount of the substance to achieve the same desired effect. Withdrawal syndrome. A set of symptoms that are experienced when the use of medication or recreational drugs is stopped suddenly. The intensity of withdrawal syndrome can range from mild, like caffeine withdrawal symptoms, to severe and life-threatening. For example, alcohol withdrawal symptoms can include seizures. Common withdrawal symptoms include physical symptoms like sweating, tremors, and nausea, as well as psychological symptoms such as anxiety or hallucinations. Risk factors in the development of addiction. Genetic vulnerability. Genes alone cannot explain addiction, as there must be some exposure to the addictive activity or substance for addiction to occur. However, there are genes that alter body function that make some people more or less susceptible to the effects of drugs, which can influence addiction. This could be genes influencing brain functions. The number of dopamine receptors in the brain has a genetic basis, and low numbers of the D2 dopamine receptor is linked to addictive behaviour across a range of addictions, even to substances that don't influence dopamine directly, suggesting the reward system of addicts functions differently. Addiction may be more or less likely due to how their body processes the drug. 50% of Asian people feel unwell when drinking alcohol. This makes this group of people far less likely to develop alcohol addiction than Westerners. Stress. Many addictive drugs function by temporarily improving mood, meaning people with high levels of stress are more likely to be drawn to the drugs for temporary relief, and this increased exposure means they're more likely to become addicted. Extreme early life stress, such as abuse, can influence brain development, producing a diaphysis, vulnerability, making a later addiction more likely as a way to cope with later life challenges, stresses. Personality. Eisnick, 1997, suggests individuals who are neurotic and psychotic are more likely to form addictions. Neurotic people are highly anxious and easy to upset, and psychotic people are often impulsive and emotionally cold. Family influences. The attitude of the family towards the use of addictive substance is linked to the likelihood that the children will use the substance or activity. For example, parents who approve or themselves use tobacco, gambling, or alcohol are more likely to have children who use these, even if they disapprove of their own child's use. Social learning processes also increase the risk of the members will become addicted. Everyone says my brother looks cool smoking. Peers. Trying addictive substances can be encouraged by peers. Conformity processes can also play a role with drug taking due to compliance or identification with a group. This results in popularity in the group, but continued use results in addiction. Peers can also discourage the use of addictive substances when in their presence. Evaluations. Genetic vulnerability. Suggesting genetics are a risk factor is biologically reductionist. There must be some interaction with the environment for exposure to the addictive substance to start. Twin family and adoption studies indicate there is a higher risk of addiction if a close family member has an addiction. However, concordance rates are never 100%, suggesting an interaction between genes and environment. Stress. Stress may be correlated with addiction due to the stress caused by the addiction itself, such as financial and family. Many addictive drugs do result in a temporary reduction in anxiety, and some illegal drugs have even been prescribed as anti-anxiety medication, suggesting people do attempt to self-medicate but become addicted. Personality. An addictive personality is a myth. There are many people with the personalities linked to addiction who are not addicts. Certain personality factors such as risk-taking clearly make it more likely someone will try an addictive substance. Family influences. The interaction between family genetics and social factors within families who live together are difficult to separate. It may be that all members of a family have a shared genetic weakness to a drug, regardless of interpersonal interaction. The knowledge that family opinions shape children's views towards drug use can be used to inform conversations within the family regarding appropriate use. Peers can't explain all addictions, as some addictions, like sex addiction, are highly secretive in nature. Practical applications. Schools are able to use education to inform the wider student body of the danger of addictive substances. Convincing the majority of a peer group should mean that members of a friendship group should self-police. Explanations for nicotine addiction. Brain neurochemistry refers to neurotransmitters. These neurochemicals regulate brain activity. Nicotine influences dopamine, a neurotransmitter vital for the function of the brain's common reward pathway. Nicotine binds to nicotinic acetylcholine receptors in the ventral tegmental area, VTA, ultimately leading to dopamine release in the brain's reward center, the nucleus accumbens, a part of the mesolimbic system. The role of dopamine. Dopamine activation creates feelings of euphoria and reduced anxiety. Withdrawal and tolerance contribute to addiction. The withdrawal symptoms are due to an increased sensitivity of nicotinic receptors during abstinence. Tolerance develops as more nicotine is required for the same effects. It's thought the imbalance of neurochemistry is ultimately due to a genetic abnormality, in this case with a variant of the DRD2 gene. This gene encodes the D2 subtype of the dopamine receptor. Variants of the DRD2 gene are associated with cocaine, alcohol, and opioid dependence, as well as obesity and even gambling addiction, supporting the hypothesis that DRD2 is a reinforcement reward gene, acting by influencing the dopamine system. There is evidence that other neurotransmitters, GABA and serotonin, have a role in nicotine addiction, as well as psychological factors such as cue reactivity and aspects of social learning theory. This suggests that the dopamine explanation is overly simplistic, reductionist. Human and animal studies are both used in nicotine research, biological and learning theory. However, due to ethical concerns, human research is only correlational, and the controlled experimentation on animals, while demonstrating cause and effect, may not be generalizable to humans due to factors such as willpower and an understanding of negative consequences. Understanding the biological aspects of nicotine addiction has important economic implications for the NHS. Early investment in biological treatments, patches, can reduce the physical harm caused by smoking, limiting future costs to health services. Learning theory. Learning theory as applied to smoking behaviour includes classical and operant conditioning and social learning theory concepts. Smoking behaviour has a pleasurable psychological effect, a reward. This acts as a positive reinforcement, increasing smoking behaviour, while stopping smoking acts as negative reinforcement. Cessation leads to the unpleasant psychological effects of withdrawal, for example, cravings and irritability. To avoid these symptoms, smoking is continued. Cue reactivity. Addicts develop a learnt response to objects and situations they associate with drug use. Exposure to these cues can trigger cravings and continued use, maintaining the addiction. For a smoker, a pack of cigarettes acts as a discrete cue, the substance, and a pub would be a contextual cue, the environment. Social learning theory explains the acquisition of smoking addiction. It explains why a substance that is known to be addictive and harmful is first tried. Young adults and teens observe smoking modelled in older peers and attractive members of the media. The smoking behaviour is referred to or depicted as cool. This praise acts as vicarious reinforcement, with smoking behaviour imitated in an attempt to gain similar status. Drobes, 2000, compared the response of alcoholic smokers, non-alcoholic smokers, and healthy controls, neither, to photographs of 10 smoking cues, along with other non-smoking pictures. Found both smoker groups found stronger cravings to smoke, along with increased arousal, interest, and a lack of control while viewing the smoking-related cues. Learning theory is ineffective in explaining individual differences in addictive behaviour. For example, some individuals become highly addictive while others can smoke occasionally, socially, without developing an addiction. Understanding the psychological aspects of nicotine addiction can be used for cessation strategies, such as avoiding people and situations associated with smoking, or providing symbolic models to promote anti-smoking in the media. Learning theory as an explanation for nicotine addiction in isolation is reductionist. There is significant evidence that neurotransmitters, dopamine, GABA, serotonin, have a significant role in nicotine addiction. This means it may be better to invest in biological treatments, like nicotine patches, and research the interaction between biological factors and learning theory. Explanations for gambling addiction. Learning theory as applied to gambling includes classical and operant conditioning and social learning theory concepts. Classical conditioning, cue reactivity. Through experience, gamblers associate certain situations with gambling, the pub, sports fixtures. Being exposed to these situations in the future leads to a psychological urge to gamble. Operant conditioning. Gambling behaviour is positively reinforced by a win. As a win results in excitement, praise, a positive consequence, this win makes it more likely for the gambler to repeat the gambling behaviour. Gambling systems like slot machines use partial reinforcement. Not all bets result in a win, but enough bets do that gambling behaviour does not become extinct. Predictable fixed ratio schedules of reinforcement, for example winning every fifth bet, are not as effective in producing compulsive gambling as unpredictable variable reinforcement, for example winning on average once every 5 bets. This has no fixed pattern, so the next bet could result in a win. Social learning theory. Ad companies, lottery and sports betting show examples of people winning bets as they act as models for our own behaviour. Seeing others win large sums is vicarious reinforcement for our gambling behaviour. Children who observe parents and older peers showing excitement at gambling or winning will likely observe and imitate this behaviour later in life due to mediational processes. The behaviours principles behind classical and operant conditioning are well supported by animal research. For example, Skinner's pigeon research shows the power of variable reinforcement in producing compulsive behaviour that is resistant to extinction. Classical and operant conditioning can explain how addiction is maintained, but struggles to explain how one begins. The opposite is true for social learning theory. A holistic explanation combining both may be more valid than either alone. Many individuals can occasionally gamble without developing a compulsive need. This indicates significant individual differences influencing gambling behaviour, such as in biology or personality. Suggesting learning theory alone is reductionist. Understanding the role of learning theory in gambling behaviour has led to government policies to try and reduce its harm. For example, outlawing video game loot boxes aimed at children and placing regulations on gambling advertisements. Cognitive theory as applied to gambling. Gambling addiction is a result of faulty thought processes. Cognitive distortions that bias gamblers' perception of their control over future events and ability to predict their probability. The first gambling cognitive bias was identified by Langer, illusion of control, when people expect success at a higher level of certainty than objective probability. This is due to being able to choose or act, for example lottery numbers, favourite slot machine, throw the dice. This has no influence over the gambler's likelihood to win, but simulates skill. Wagner later added 15 additional cognitive biases, including perceptual bias, the gambler's fallacy, a belief that a win is more likely after a series of losses. Selective recall. Gamblers are more likely to remember the times they have won than the times they have lost. Near win bias. A near miss is not interpreted as a complete loss, but almost a win. Ritual bias. The gambler can control outcomes by completing an act that increases their luck. Lucky socks or a pen. Griffiths, 1994. 30 regular and 30 non-regular gamblers were asked to think aloud while gambling on slot machines in a real arcade environment. Regular gamblers were significantly more likely to produce irrational verbalizations and refer to themselves as above average skill, even though slot machines are games of chance. While the evidence seems to suggest gamblers have cognitive biases, the evidence is correlational. It may be the cognitive biases result from problem gambling, developing as a way to cope with loss, not a causal factor. While cognitive biases are effective at explaining how gambling behaviour is maintained, it's less successful at explaining how gambling behaviour starts. Initiating gambling behaviour may be better explained by social explanations. Cognitive theory has been practically applied to adapt CBT as a treatment for gambling. Oakley-Brown's 2000 meta-analysis of 4 trials comparing CBT for gambling to control treatments found CBT has a moderate, high level of benefit in the short term and a moderate level in the long term. The effectiveness of CBT as a treatment suggests the cognitive concepts are valid. Reducing addiction. Drug therapy, also known as pharmacotherapy, means the treatment of disease through the administration of drugs. These drugs are specifically chosen to interact with the body in the way that can prevent, diagnose, alleviate, or cure disease. Replacement therapy. A drug therapy where a safer, controlled substance is used to replace the substance the person is addicted to. This reduces the harmful effects of the substance while also controlling withdrawal symptoms and cravings. An example is methadone in the treatment of opioid dependence. Blocking antagonist drug therapies bind to the same receptors in the brain as the addictive substance, but do not produce the same high or sense of euphoria. The presence of these drugs in the synapse prevent the addictive substance from having the desired chemical and psychological effect. For example, naltrexone for opioid and alcohol addiction. Aversion therapy, a combination drug therapy and behavioural intervention. Based on behaviourist principles, it attempts to reduce the desire to consume harmful substances by associating the drug with unpleasant sensations or experiences. For example, if an alcoholic takes alcohol alongside an emetic drug, diazepam, it will cause vomiting. In this essay, focus on the drug aspect. Matic 2009 conducted a meta-analysis of 11 randomized clinical trials that compared methadone as replacement therapy to placebo or other non-pharmacological therapy, found methadone was significantly more effective in suppressing heroin use as measured by self-report and urine and hair analysis, and was more effective in keeping addicts in treatment programs. Drug therapies can have side effects. For instance, methadone can cause respiratory issues and irregular heartbeat in some individuals, while disulfiram can cause liver damage. Drug therapies don't address the underlying psychological or social factors contributing to addiction, such as trauma, stress, or lack of social support. Drug therapies are more effective in the long term when combined with other forms of treatment. As drug therapies reduce withdrawal symptoms without the motivation required from other forms of treatment, such as CBT, it may be a more effective treatment path for individuals with severe addiction. Behavioural interventions. Aversion therapy, a combination drug therapy and behavioural intervention, is based on behaviourist classical conditioning principles. A noxious substance, unconditioned stimulus, is paired with an undesired behaviour, a neutral stimulus. The unconditioned stimulus causes an unpleasant effect, the unconditioned response. Through association, the neutral stimulus acquires properties of the unconditioned stimulus and becomes a conditioned stimulus, creating an unpleasant conditioned response. To avoid the conditioned response, the conditioned stimulus is avoided. For example, when treating alcohol addiction, disulfiram is the unconditioned stimulus. Alcohol use is first the neutral stimulus and then the conditioned stimulus, and vomiting is the unconditioned response and the conditioned response. In this essay, focus on the behavioural aspect. Covert sensitization is a behavioural intervention that uses adversive imagery to reduce the desire for the addictive substance or behaviour. Stages. 1. Relaxation. The therapy session begins with the therapist guiding the individual into a relaxed state. 2. Imaginal exposure. Once relaxed, the individual is asked to imagine engaging in addictive behaviour, for example, obtaining, using, and immediate positive effects. 3. Adversive consequences. Asked to imagine experiencing negative consequences, for example, severe illness, physical, loss of relationships, social, arrest, legal. Positive imagery. The individual imagines choosing to do something positive and rewarding, not the addiction. Muchler, 2016, reported on a meta-analysis of 22 randomized controlled trials on aversion therapy, finding disulfiram more effectively reduces alcohol consumption than anti-craving substances. However, participants in placebo groups, thinking they had disulfiram, reduced consumption as much. This suggests expectation reduced alcohol use, not association. As aversion therapy, covert sensitization, is based on behaviorism, it only focuses on outward behaviour, not the original cause. The original cause is likely to be cognitive, social, or biological, so it's possible the drug will be used again. And without the presence of the noxious stimulus or imagination of adversive consequences, the original association will return, resulting in relapse. As aversion therapy causes actual harm, disulfiram causes vomiting and liver damage. The client needs to be willing and motivated to complete the treatment. Covert sensitization requires high levels of motivation and the capacity for imagination. Aversion therapy and covert sensitization is used with a wide range of addictions, both drugs and behaviours, like gambling. Cognitive behaviour therapy, a psychological treatment that assumes maladaptive behaviours, such as drug or alcohol use, are the result of irrational thought processes. The goal of CBT is to help individuals develop healthier thought patterns and coping skills that will help them to manage stress, resist cravings, and ultimately avoid relapse. The therapist would first use cognitive appraisal to help the addict identify their maladaptive thought patterns and triggers for those beliefs. For example, an individual might believe they need drugs or alcohol to cope with stress at work. Next, cognitive restructuring is the therapist working with the individual to challenge and change these beliefs. CBT then focuses on skills acquisition, developing abilities such as stress management and assertiveness, and developing self-monitoring strategies to identify triggers and manage cravings. Role play of potentially difficult situations. For example, the therapist might simulate a social situation where drugs or alcohol are present, and the individual would practice using their new skills to resist the temptation to use. Relapse prevention includes identifying potential triggers, developing strategies to manage these triggers, and planning for how to handle any lapses that might occur. Hoffman 2012 reviewed 269 meta-analyses of CBT, including 18 on addiction, found CBT was highly effective in treating cannabis and nicotine dependence, and still effective, but less effective, for treating opioid and alcohol dependence. CBT alone may not be sufficient for individuals with severe or complex addiction issues. A combination with drug therapy may be needed to reduce cravings, and social factors relating to poverty or abuse may need addressing first. Due to the demands placed on clients, time, effort, emotional strain, CBT has a high dropout rate. This means CBT is only appropriate for clients who are willing to engage fully with the process, motivation, and can communicate clearly. CBT has more significant long-term beneficial effects than other therapies, for example, increased confidence. Rather than just temporarily suppressing cravings, CBT deals with the maladaptive thought processes that first led to addictive behaviour. Hey there, as you're still watching, I'm guessing you'll find this video useful. As I release content right up to the exams, don't forget to subscribe so you know when new videos are uploaded. Also, as this video is being released, I'm on around 50,000 subscribers, and I'd love to get to 100k at some point in the next few years. The theory of planned behaviour, a theoretical model showing how a person comes to a decision to change a behaviour. This has been applied to a range of addictive behaviours. There are 3 interacting components. Subjective norms, the addict's beliefs about their support network's views on their addictive behaviour. Do the views of those around them create a social pressure to quit, or to continue the addictive behaviour? For example, all friends drink on a Friday night. Behavioural beliefs and attitudes. If the addict themselves has an overall positive or negative opinion of their own addictive behaviour. For example, drinking is an important part of my social life versus drinking is causing significant health issues. Perceived behavioural control. If the addict thinks they can actually give up the addiction or not. For example, I don't have much willpower and alcohol is everywhere. There's no way I can give up. This influences how hard they try to quit. These 3 aspects combine, resulting in behavioural intentions, what the individual plans to do. While this may or may not actually result in behavioural change, the action of giving up with addiction, but the intention is needed to attempt change. This diagram is often credited. Evaluations. Armitage and Connor 2001 conducted a meta-analysis on 185 studies on the theory of planned behaviour, finding it is successful in predicting both behaviour and intention, but better for intention. Also, subjective norm is the weakest predictor of intention and behaviour. The theory of planned behaviour does not fully include the role of emotional factors in decision-making, focusing mainly on logical mental processes. While the theory of planned behaviour is an effective predictor of behavioural intention, it is less successful in predicting actual behavioural change, which is the most important element when attempting to help someone overcome addiction. While it's not in itself a strategy to help someone recover from addiction, its principles have been applied by therapists in treatment, such as ensuring a supportive social network, changing attitudes, and improving self-efficacy. Prochaska's 6-stage model of behaviour change. The process of behaviour change is not linear, unhealthy directly to healthy, but cyclical, a series of stages that may need to be repeated multiple times, with frequent backward steps. Pre-contemplation, not currently considering addiction as a problem, that there's a need for change. Contemplation, starts to consider a change in addictive behaviour, weighing up rewards and costs of change. Preparation, decided to take action, planning how to reorganize life. For example, avoiding events with addictive substances. Action, is the first 6 months of trying to stop the addictive behaviour, substance. Informs friends, removes temptations. Maintenance, 6 months plus since started action stage, starting to feel goal can be achieved, less likely to relapse. Relapse is a return to a previous stage in the model. Relapse is most likely at the action stage, but also maintenance. Termination, the addictive behaviour is stopped and the individual no longer feels addictive temptations. Evaluations, Prochaska's 6-stage model may be a more valid view of addiction recovery, not focusing on addictive behaviour as an all or nothing, but a slow, gradual process with a number of steps backwards. This is likely to fit better with many people's experience of recovery. The clear identification of stages should be helpful for therapists who, understanding what stage their client is in, can better shape the particular support and therapy they offer. Behaviour, 2009, conducted a trial of 2,471 UK smokers and randomly assigned half to a program based on the 6-stage model and the other half to a control group. The findings showed no significant benefit to stage-based intervention. It can be problematic to clearly identify the particular stage that someone's in. For example, what particular actions mark a transition from planning? And has someone achieved maintenance in month 6 if they had some relapse in month 2? The inclusion of failure as part of the model can be seen as a humane approach to addiction and should give comfort and confidence to people who are attempting and failing to recover. Don't forget you can now test yourself on the addiction unit with the PsychBoost app. If you want to try out the app, all of the topics in paper 1 are free, and you can get it on iOS or Android. If you want to see model answers to questions or access my other resources, there's also Patreon. Speaking of Patreon, I do want to thank all of my patrons for their support. With the help of all of these students and teachers, I'm able to teach part-time so I can work on the main mission of PsychBoost, the development of a free-to-watch and hopefully high-quality A-level psychology course. And a special thank you to Kat Posnick and Ahmed Ramani for supporting at the developer level. So thanks to them, good luck to you with your revision, and I'll see you in the next PsychBoost video.